Kiki is only 5 days old. She has been rushed by ambulance to the resuscitation room at the emergency department. Kiki's mommy woke up this morning after a long night with little sleep to find her in her cot, looking mottled and breathing very fast. She immediately calls for an ambulance and Kiki was rushed to the hospital. Kiki was born at 38 weeks gestation by normal vaginal delivery in a midwife-led community birthing unit and was discharged home the same day. There was no prolonged rupture of membranes and she did not require any resuscitation at birth. She has been exclusively breastfed. However, she did not receive vitamin K due to objection by her parents. On arrival, the airway is maintained, high flow oxygen is administered, intravenous access is obtained, and fluid resuscitation is given for the shock. Blood glucose measurement is checked and a blood gas sample is taken for analysis. Intravenous antibiotics is given promptly due to the likelihood of sepsis. On examination, Kiki is has a respiratory rate of 70 per minute with subcostal, intercostal, and sternal recession. Her lung fields sound clear. Oxygen saturation monitoring does not pick up a trace. At this point, Kiki still looks mottled with some degree of stenosis peripherally and her limbs feel cold. Capillary refill time is 5 seconds. The heart rate is 180 per minute. Blood pressure is unrecordable and the femoral pulses cannot be felt. The heart sounds are unremarkable. The liver edge is palpable 3 centimeters below the costal margin and her temperature at this point is 35 degrees Celsius. Her arterial blood gas is analyzed and the pH is 7.01, which indicates a severe acidosis. The PaCO2 or partial pressure of arterial carbon dioxide is normal, so this acidosis is not respiratory in origin. Also, there is low bicarbonate and large negative base excess, which indicates that this is a metabolic acidosis. There is also a degree of hypoxemia. Now, Kiki's circulation is so poor that pulses are not palpable. The saturation meter cannot pick up a pulse trace and a severe metabolic acidosis has developed due to the hypoperfusion. A preliminary diagnosis of cardiogenic shock due to a congenital left heart obstructive lesion is proposed. The clues leading to this proposition was her age and the absence of the femoral pulses. Left-sided obstructive cardiac lesions rely on the ductus arteriosus to perfuse the systemic circulation by passage of blood from the pulmonary arteries into the distal end of the aortic arch. Now, the ductus arteriosus closes about 11 days after birth, and Kiki is now 5 days old. The supply of blood to other parts of the body is dramatically reduced, resulting in collapse and shock. After extensive analysis of the data and the discussion among the team of medics, Kiki was diagnosed as having hypoplastic left heart syndrome. Hypoplastic left heart syndrome is a rare congenital heart defect in which the left heart is severely underdeveloped. There is no known cause in the majority of cases, but there could be a genetic component. Kiki is successfully resuscitated and she is currently stable.